Hello, try two, try two. Hello, try two, try two. Can do here. Uh, hello, try two, try one, two. Hello, try two. Hello, hello. Hello, try two, try one, two. Hello, hello, try two. Okay.
It's not connected. Hello, good afternoon. Try one, two.
Can you hear me too? It's fine.
Hello.
That's on. So good afternoon, ladies and gentlemen, and good afternoon to all our participants. The softball coming your way again from the College of Physicians and Surgeons, REG. Today we are privileged to come your way again with our sixth CPD, which is going to be on the topic early detection and management of chronic kidney diseases in primary care. And today we are privileged to have very distinguished scholars with us who will be taking us through. I hope that over the past few weeks, you've benefited from most of these CPDs, but this is all in collaboration with a lot of partners. And today we have our partner, Boehringer Ingelheim, with us. And also, this is also in tune to get us to our AGSM, which is coming off from the 21st to the 24th of May. So kindly keep the date, save the date, and join us at the AGSM at Takoradi between the 21st to 24th of May. We'll start with a prayer. We want to call on our pastor of the house, Barnabas, to give us a quick prayer as we start the meeting. Barnabas.
Okay. Shall we all pray? Our Heavenly Father, we thank you once again for this opportunity to be in your presence. We pray and commit this program into your hands, and we ask that you start with us. Make sure every single presentation here will be beneficial for every person who has joined online. And at the end, we'll give you honor and glory. This we pray through your Son, Jesus Christ. Amen.
Amen. So it's my privilege today, as we gather today at this time, for us to go through chronic kidney diseases, because it continues to pose a growing public health challenge, often progressing silently until advanced stages. In fact, it's a major problem for us at the primary care facilities. As primary care physicians and healthcare professionals, we stand at frontline for prevention, early detection, and timely interventions, and long-term patient support. This makes today's conversation indeed not only relevant, but essential. This afternoon really promises to be engaging and practical as we explore current approaches to screening, staging, identifying risk factors, and evidence-based management of chronic kidney disease within the primary care setting. We are particularly privileged to have experienced resource persons who will share valuable insights to strengthen our clinical practice and improve patient outcome. First on bill, we're going to look at the topic, screening, staging, and risk factors for chronic kidney disease. To do that for us, we have a very distinct person. It's my pleasure to introduce to you our first speaker, my own friend and a partner in crime, currently taking over from me as our able president of the Society of Family Physicians of Ghana. She is an accomplished senior family physician at the Korle Bu Polyclinic Family Medicine Department at the Korle Bu Teaching Hospital. She is a fellow of the Ghana College of Physicians and Surgeons. And as I said, she's currently the only president of the Society of Family Physicians of Ghana, where she continues to champion quality primary healthcare, preventive medicine, and professional development among family physicians in Ghana. With over a decade of clinical experience in frontline healthcare delivery, Dr. Damoah has extensive expertise in the management of chronic, non-communicable diseases commonly encountered in primary care, including hypertension, diabetes, cardiovascular diseases, and chronic kidney disease. She has a special interest in cardiovascular medicine, with particular focus on prevention, risk reduction, and improving outcomes for patients living with chronic conditions, leading to her earning a diploma in preventive cardiovascular medicine from the University of South Wales, UK. This afternoon, she will be speaking to us on screening, staging, and risk factors for chronic kidney disease, an essential topic that will equip us with practical insight into early identification and prevention of chronic kidney diseases in our everyday clinical practice. Ladies and gentlemen, help me as we welcome Dr. Baba Nina Damoah. Dr. Damoah, please, you have the floor.
Thank you very much. our global president, as I always say, and thank you to the Society of Family Physicians for this opportunity to step in to discuss, to talk about something that is gradually growing its ugly head in our primary care facilities, and a lot of attention is not given to. So I'm glad to be here this afternoon to talk to you about this condition. So let's see. Okay, I want to be sure my slides are moving. It doesn't seem to. Let me share again. Okay, so by way of outline, I'm hoping that at the end of our discussion, we'll be able to understand the global and local epidemiology of CKD. We'll be able to identify some risk factors and causes. We will recognize how important it is to have early detection and screening, some of the screening methods we can use in primary care. And most importantly, we will be able to put in prevention strategies in our primary care to reduce the burden on our able nephrologists, who are not many in the country, by the way. And then we also explore some technologies in CKD detection that has come in vogue. So by way of definition, chronic kidney disease is characterized by a kidney structure or functional abnormalities, or an estimated glomerular filtration rate of less than 60 ml per minute per 1.73 meters square, persisting for 3 months or more. Early detection of CKD is key because, as you realize as we go along, presentation along the earlier stage is usually asymptomatic. So it's important that we look out for it. And the management of CKD, especially for primary care, will involve how we adjust their medications, we address reversible causes and their risk factors to reduce disease progression, and how we will prepare these patients for renal replacement therapy should they get to end-stage kidney disease. So globally, the prevalence is between 13% to 15%, and particularly in Africa, we have the same burden, almost 14% of prevalence. But I must say that although we have the same prevalence as high-income countries, less than 3% of people have access to renal replacement therapies in Africa, compared to well-developed world where you have a large number of people who have access to it. So it's important that we put this into perspective as we see our patients in the clinics. Majority of the CKD patients that we see is caused by cardiovascular diseases like diabetes or hypertension. Indeed, 1 in 3 adults with diabetes may have CKD, 1 in 5 adults with hypertension will have CKD. But the other important causes like glomerulonephritis in our sub-regions where infections tend to be a lot. So it's also something that we should look at. When you are Black or African-American population, you are exposed to an almost 4 times higher incidence of end-stage kidney disease compared to white population. And this is important as most of the patients that we see are Blacks, and shows how aggressively we should manage these risk factors and problems that they have so that they don't end up with CKD. In a developed world like America, a study found out that with 26 million adults affected, the amount of money allocated for dealing with patients with CKD was $42 billion. There's a lot of money, and to think that in our sub-Saharan Africa, in Ghana to be precise, to be difficult to come out with this money to allocate to help with Medicare or medical treatment for patients with CKD. Indeed, this morning, I listened to the chairman of the Mahama Trust Fund, and who spoke about how costs costly it is for medical care in Ghana, especially for the people that they've enrolled on. And CKD management, as you find out, is also very cost intensive. So this puts frontline workers like primary care doctors, family physicians, medical officers, those of us who mind the primary care in Ghana, in a defender fence where early detection will be the most effective intervention we can do to prevent patients from going on to end-stage renal disease and having cardiovascular mortalities. Aside this, having CKD also affects your quality of life. Our family physicians, we are concerned about it. It leads to loss of productivity at work. There's caregiver burden. Somebody have to carry you to have dialysis done 3 times in a week if you are not able to go on your own. And then there's also severe cardiovascular diseases. Renal CKD will now predispose you to getting other cardiovascular diseases as well. Hypertension becomes difficult to control, leads to resistance. That in our 4th CPD. So the problem becomes enormous. And that's why we are here this afternoon to make sure that we are able to fill that gap. Truthfully, it is believed that the prevalence is way above 50%. So as we sit in our day-to-day clinic and you are seeing these patients, we should have at the back of our mind that a lot of them are missed. And they are missed because, one, we don't screen them to diagnose them early. 2, we don't also code the diagnosis very well. Now, EMR is everywhere in Ghana. Most facilities are using it. So patients will not be rightly coded to having chronic kidney disease, and because of that, expose them to further risk, which worsens their plight. So if you look at this, you realize that a lot of people are leaking out of our clinics. And at the end of the day, we identify just about 12 or 13% of them as having CKD. So what can we do? We should recognize the testing gaps, the gaps in our primary care that is making us not pick up patients with CKD in time to help them to slow down the disease process. And one of the gaps is the testing gap. A lot of us focus on the estimated glomerular filtration rate, which actually tests for kidney function. Almost 90% when you did a study in a primary care facility will test for this. But before this will calm down, the first marker will be urine albumin-creatinine ratio, which is almost like half of the practitioners will look out for. And this actually talks about the kidney damage, the endothelial damage that takes place before kidney function deteriorates. So this gap alone will make a lot of patients with CKD go on in our primary care clinic without us picking them out. The second gap is the interpretation gap, which I call the 3 months rule. If you go back to our definition for CKD, you realize that you need 3 months. The eGFR reduction, structural problem, functional problem of the kidney, it must persist for at least 3 months for you to make a rule, the diagnosis. So what happens when the patients have CKD already, you don't know, presents your facility for the first time with eGFR below 60, because you have not followed up these patients for 3 months, you don't know the history, there's nothing in the EMR to tell you, you cannot make up the diagnosis of the CKD. So it takes 3 months gap for this patient to still have the risk factors that is promoting the CKD to happen. And this also does not help us in primary care. So this gap is also, that's why it's important that we address all this and not leave it a blank. I must also say that you cannot also see somebody with a reduced eGFR and quickly go to diagnose CKD, as it can also be an AKI or acute kidney disease. So that's why this definition is important. In fact, KDIGO strictly defined this by the time range, and this becomes an interpretation gap that we must also think about. Then, like I mentioned earlier, there's a documentation gap where people don't code correctly. You don't put the diagnosis up. You are seeing a patient with diabetes, with hypertension, and you've also diagnosed CKD. Because you don't code it, the information does not go on to other members of their health team, so that, for instance, if you are not going to put this patient on NSAID, they are aware that this patient has CKD, so we should not prescribe NSAID for this patient. So then the patient will now get exposed to it. Patients will have mixed routine follow-ups because he's not aware that I have a chronic kidney disease I have to come in. So this gap is also one of the main gaps that affect us in primary care that we should also have at the back of our mind as we see our patients. So let's move on to the risk factors. Some of the risk factors are non-modifiable, like increasing age, gender. CKD is known to be more prevalent in male sex than female sex. Like I mentioned earlier, Black ethnicity also predisposes you. And genetic components, if you have a family history of polycystic kidney disease, some hereditary disorders, it will also predispose you for getting CKD, then low birth weight. But majority of the causes, and in fact, the main drivers of CKD are modifiable that we can do something about. I'm talking about hypertension, diabetes, drug toxicity, some antibiotics that we use, NSAIDs, people abuse. And in Ghana, it's so easy to get medications out on the pharmacy without a prescription. So before they come to you, they would have taken something or gone to take it before they come to primary care. So you should also bear that in mind and advise appropriately. Other risk factors include obesity, dyslipidemia, then high uric acid level, autoimmune diseases, recurrent urine tract infections, as if first DPD on recurrent urinary tract infections also predisposes you. Especially, I need to.
Reload the presentation. Thank you.
Okay, so apologies for the technical hitch. As I was saying, if you have urinary tract obstruction, it also increases or predisposes you for getting CKD. So what are the causes of CKD? The primary cause, like I mentioned, diabetes for Ghana. For studies in Ghana have shown that diabetes, hypertension, glomerulonephritis drives it. But we can also put the causes as pre-renal, intrinsic renal, and then post-renal. And as you can see from the diagram, intrinsic renal really forms the majority of the cause that we have for CKD. How do they present? Like I always will want us to do, as we sit in our clinic, a lot of them will not come out and show. Like if your patients have hypertension, you are going to realize that blood pressure is high and go to diagnose. But most patients with CKD, it's a silent phenomenon, so they are asymptomatic. A large chunk of them will not show any symptoms at all. So this is why we need to look out and screen for them. Aside this, they may present with things like nausea, unable to pass enough urine, sleep disturbances, some symptoms and signs of fluid retention, difficulty to breathe, pedal edema. When they have high uric levels, they are going to present with uremic froth, which is usually on their skin. And then they may also have a pericardial rub or friction. Most importantly, most of them do not have their blood pressures controlled. It may be very high. So they may have hypertensive fundal changes when you look at the eye. So how do we screen? Now that we know the importance of screening, how do we screen for them? The first one will be the filtration assessment, where we order our EGFR and then it measures the function of the kidneys. Now the guidelines moving towards adding cystatin to it. Then you can also do urinalysis, urine albumin creatinine ratio. This talk about endothelial damage and usually the first sign of kidney disease, and this is what we can also do. There may be morphological assessments where you have an ultrasound, CT scan, radiology to identify and actually look at the kidneys. In CKD, the kidneys are smaller, as I'll show on the next slide. Kidneys will appear smaller. There will be poor corticomedullary differentiation, and if it's polycystic ovarian disease, polycystic kidney disease is the cause, you may actually see the cystic damages on the kidney as well. Now, there are AI-based predictive tools that can also predict and examine ultrasound, x-rays of the kidney and actually let us know if the patients have early signs of chronic kidney disease. So apart from, like I mentioned this already, there may be scarring or multiple cysts that you can also see on the ultrasound finding as well. So as we see our patients, let's know that when we first need to screen them. And as we screen them for function using our EGFR, when it's less than 60, we'll need to wait and repeat within the 3 months. And within the 3 months, at least 2 of the tests has to be positive for us to confirm the CKD diagnosis. According to KDIGO Code 2024, it is important that when we diagnose CKD, we diagnose per these pillars, which is the cause of the chronic kidney disease, the EGFR category, and then the albuminuria category. I'll show a heat map, but before that, we should think about the causes. So anytime you have a patient with CKD, yes, it's a diagnosis, but you should be driven by what is causing these patients chronic kidney disease. Is it a systemic disease like diabetes, hypertension, autoimmune like lupus? Is it genetic or structural? Is it iatrogenic? Is it by toxins. It is important you state this because that's how you can further reduce these risk factors and cause and make sure that the chronic kidney disease do not progress to end-stage kidney disease. The second pillar is your eGFR. And this one, I'm sure most of us is aware, when eGFR is greater than 90, we say you are normal. Between 60 and 89, it is mildly decreased. Between 30 and 60, we are in group stage 3, where we say it's mild to severely decreased. Between 15 and 29, we say you are in stage 4, severely decreased. And then end-stage renal failure is when you have eGFR less than 15 and you are in stage 5. Like I said, now the teaching is to combine it with cystatin C to actually give a good classifying value based on the eGFR. Then our third pillar is to assess for albuminuria, where we have normal to mildly increased when it's less than 30 milligram per gram, or moderately increased when it's between 30 to 299. And then when it's greater than 300, you say it is severely increased. Like I said, this shows endothelial damage and is the first monitoring test we can do in primary care to assess for kidney function. It is not expensive as doing the eGFR, and it's something that we can all think about as we sit in the districts and primary care level in Ghana. So then I present this heat map. This heat map is something that should help us classify our patients and know how we are going to monitor them, when to refer to our able nephrologists like Dr. here with me, who, like I said in the beginning, they are not a lot, for them to manage the case and all that. So if you look at it, green is, if I say, stable patients, and these patients can be followed up once in a year in primary care. They don't need to move on to secondary care or tertiary care. And usually people with eGFR 60 and above, but will have albumin levels that is less than 30, will be these people. Then there's also yellow, who have a slightly increased risk, but can still be seen in primary care. And it will be good to also follow them up every year with a repeat to make sure they are not progressing, their risk factors are also reduced. Then we have the orange group, who are a slightly higher risk. They can also be seen in primary care specialists. If specialists are operating that primary care level, you may have to see them once or twice or thrice, depending on what is there. And sometimes you can have a patient with eGFR in stage 2B, which you would have classified as very low, but because albumin category is low, this patient can still be followed up. It will be orange, and this patient can be seen in primary care, compared to someone who have high albumin levels and eGFR, you say, is in stage 2. This is more severe and need to be referred to see the nephrologist. So it goes down to the most severest form, where the patient has end-stage kidney failure and also severe albuminuria. These people will have to be sent to the nephrologist. So I've said this already, and the high-risk people sometimes need to be followed up as much as more than 3 to 4 times in a year. So it's important that we recognize and pick them up and coordinate their care with their specialists so that they can see that. Aside this, in primary care, what we can also do is to institute lifestyle modification, helping with their diet optimization, giving them a structured exercise to do. If we help them to reduce their weight, it helps to help them to reduce their risk for CKD progression. If they are smoking or they are taking excessive alcohol, we ask them to stop. We can also have to be strict on their blood pressure control and their targets. See how we can come to a common ground to make sure that they reach their target goals, and not just give them antihypertensives or antidiabetic medication as it is. We must be able to reach a target for them to keep their risk low. And most importantly, also advise them on adherence. Taking medication for a long time is a challenge. People will forget, it becomes difficult. And sometimes when there are no signs and symptoms to show, they feel well, so they will not want to take. So it's important that we also let them know about being adherence to their medication and to avoid nephrotoxic medication. So when are we calling the police? Well, the people I call the nephrologists to help us. When patient is in stage 4 or stage 5, definitely you need to send to a nephrologist to see. When you are having rapid deterioration, your eGFR decline more than 5 within 6 months, that's rapid, and there's something precipitating it. It's important that you go and check. If patients have severe albuminuria, we want to send to the nephrologist. If the 5-year kidney failure risk equation is greater or more than 5%, they also qualify to see the nephrologist, and you need to go. And when you are not sure of the etiology or the cause, and so that they can find it out and reduce these risk factors for these patients. So I will end soon, but before I do, I want to reiterate what is happening at primary care. So what is happening currently is what I describe as a reactive failure. We are missing a lot of the risk factors to chronic kidney disease. This leads to a silent progression in the background as we see our patient, leading to end-stage uremia or end-stage kidney disease. And then we quickly are looking for nephrologist, Dr. Inusa, to help dialyze these patients. That is the current situation. And it's really so cost intensive. At that stage, there's really nothing much we can do than to give a renal replacement therapy. What we should look, I'm hoping we can do after listening to this afternoon lecture, is to have a targeted screening level where we pick up patients who are high risk, like I said, both modifiable and non-modifiable risk factors, and screen them so that we can find out early and stage them per the KDIGO guidelines, and institute all the primary care prevention interventions that we can do, lifestyle modification, adjusting their medications, whatsoever, to slow the progression, if any at all, to CKD, so that Dr. Inusa can rest, and then he can see the few problematic ones that will get to the end-stage kidney disease. So by doing this, I truly hope that we will equip the nephrologists with the perfect diagnostic foundation for them to be able to do their job. So thank you very much for this afternoon time and making time to listen. These are my references, and if you have any questions, thank you.
Thank you very much, Dr. Baba Nina Damwa, for such an excellent presentation. I think that there are some few points there. It says that don't be reactive, be proactive. And it says that most of the chronic kidney diseases in our environment are actually mixed. It looks like only 12% out of 54% of these cases are actually diagnosed. And we need to do better. We need to pick them early. Don't wait till they get symptoms. Because saying that 80% of these cases actually are asymptomatic. So if you're going to wait till they become symptomatic, then you're going to miss them. So look out for the modifiable risk factors and make sure that you are managing them well. Know the gaps, the testing gap, and the interpretation gap. Thank you so much, Dr. Baba Nina Damwa, for such an excellent presentation. I'm sure that you are well equipped, and I'm not going to burden my brother too much with a lot of cases that will need dialysis. So our second presentation is going to be done by a very good friend of mine. I've known him for years, way back in school. Such an eloquent and a good presenter. Is going to take us through management of chronic kidney diseases in primary care. It's my pleasure to introduce to you Dr. Abdul Jalil Inusa. He's a senior specialist physician and a nephrologist at the Kolebu Teaching Hostel, Accra, with extensive experience in nephrology, internal medicine, research, and medical education. He has trained both locally and internationally, including subspecialty nephrology training at Tygerberg Hospital in South Africa, and currently plays an active role in kidney disease management, dialysis, and chronic kidney disease advocacy. Dr. Inusa has delivered numerous scientific presentations on CKD, hypertension, diabetes, kidney disease, and renal protection strategies, particularly focusing on management within primary care setting. He's actually a very good friend. He's a second primary care physician. Let me put it that way. So he's part of us. Today, he will be sharing practical insights on the management of CKD and the important role primary care practitioners play in slowing disease progression and improving patient outcome. Ladies and gentlemen, help me welcome Dr. Abdul Jalil Inusa as he takes us through the next presentation.
Thank you very much, Dr. Nketia, for such a lovely introduction. I must say we go way back, as he said, and thanks for inviting me to join your society in your celebrations. It's always a pleasure joining you. And as rightly said by Dr. Damwa earlier on, CKD, it's part of primary care. And so I'm always so excited when the primary care physicians take charge and educate us on how to prevent CKD, how to detect it early, and how to manage it, okay? So I'll be following up. Apologies for my groggy voice. I have a bit of a flu. I'll be taking over, looking at how we'd manage it after the initial brilliant presentation on screening and early detection. So this is my disclaimer. I'm actually a speaker for BI for this program. So very simple objectives I'll be highlighting here. Looking at the burden of CKD in Ghana. Of course, this has been elaborated in the first presentation. I'll try to re-emphasize the role of primary care in CKD management, as well as look at the guideline-directed management options in patients with CKD. Of course, the burden of CKD is huge, and Africa is not spared. Indeed, the prevalence of CKD is way higher than in Africa than in high-income countries. In Africa, estimates are as high as 15.8% compared to the world average of 10%. Unfortunately, Ghana is not spared, as you can see, and we are having a prevalence of 13.3%, and that is way back in the early 2020. So you can imagine that with what we are seeing now, we would be having a higher prevalence than was reported earlier on. Unfortunately for us in this part of our world, we tend to have majority of our patients with CKD in the younger ages. And indeed, from our studies, we found out that particularly those with end-stage kidney disease had average or mean ages of about 40 years. And that was quite alarming compared to high-income countries where majority of the people who have CKD are well over the age of 60. In this retrospective study that was carried out at Komfo-Anokye Teaching Hospital by one of our senior nephrologists, over a 10-year period, you can see that the outpatient attendance had increased by almost fourfold, increasing admissions due to CKD, and as many as 30% of these patients dying on admission. Another thing that was alarming from this study was that about 70% of these patients were actually presenting late, also emphasizing the fact that in early CKD, it is asymptomatic. So if we don't actively look for them, we are not going to detect it and institute appropriate therapy. So this is an excerpt from the Ghana Kidney Registry that was published in 2021. And as at the end of 2017, we had well about 680 patients on end-stage kidney disease on hemodialysis in Ghana. And you can see that the major causes, as already elaborated, were hypertension, diabetes, and glomerulonephritis. The table to the right actually also shows some other causes that were documented as contributing to end-stage kidney disease in the Ghanaian population. And as I already mentioned, the average or median age of these patients was about 40 years, and which was quite alarming as well. It's important to realize that CKD is a progressive disease, and as CKD progresses, then we get all the known signs and symptoms that we've come to know associated with CKD. And it's been already emphasized that early CKD is asymptomatic, so we should be actively looking for these patients. Again, because of the progressive nature of CKD, as CKD progresses, there's an increased risk of adverse events, such as increasing hospitalizations, increasing cardiovascular events, as well as death from all causes. It's important to realize that because of the interrelationship between CKD, metabolic diseases such as diabetes, and cardiovascular disease, you would have an interplay. And indeed, cardiovascular diseases are the major causes of death amongst patients with CKD, contributing to about 50% of mortalities in our patients. Actually, majority of our patients with CKD die of cardiovascular disease, with very few progressing to end-stage kidney disease. It's important to also highlight that eGFR, as already described, and the albumin-creatinine ratio were the strongest predictors of cardiovascular mortality amongst our patients with CKD. This implies that when you have patients with CKD, we need to monitor them with their eGFR and then the albumin-creatinine ratios as well. It's also very important to realize that there's evidence-based medications that can slow down the progression of kidney disease. And there's actually evidence to show that if you institute these measures early on, you can actually improve patients' outcomes by slowing down the progression of kidney disease, as well as reducing cardiovascular risk amongst these patients. It's therefore very important that we develop a framework, as outlined earlier, to identify patients at high risk of developing CKD, such as people with diabetes, people with hypertension, people with obesity, or other cardiovascular diseases, and screening them using both a urine albumin-creatinine ratio to determine albuminuria rates, as well as serum creatinine or serum cystatin C, if available, to estimate the GFR. It is worthy of note that we don't only use serum creatinine as a marker of kidney function. We have to estimate the GFR using approved equations such as the CKD-EPI. If a diagnosis of CKD is made, it's prudent that we risk stratify based on the heat map that was elaborately described earlier on. And based on the person's risk profile, we have to institute appropriate interventions. If patients are screened for CKD and they don't have CKD, that's not the end. Depending on their risk profile, they need to be screened periodically at various intervals so that if it is detected that they have started to develop CKD, measures can be instituted. So again, this is one of my favorite slides whenever I'm talking about CKD, particularly amongst my colleague family physicians. CKD indeed is part of primary care. Primary care physicians see all the diabetics, see all the people with hypertension, see all the people with risk factors for CKD. So beyond just checking blood sugars or prescribing blood oral hypoglycemics, beyond just checking blood pressures and prescribing antihypertensives, we need to actively screen such patients for CKD. And therefore, primary care physicians can play a significant role in early diagnosis, treatment, and patient education. And hopefully that can reduce our burden of advanced CKD requiring kidney replacement therapy. So to emphasize our management of our patient with CKD, we would use an anchor case. So this is a 56-year-old Mr. Lawson, who is known to be hypertensive for the past 10 years. Fortunately, he doesn't have diabetes mellitus, and he's a non-smoker. He's currently on amlodipine 5 milligrams daily, and he occasionally takes herbal remedies because friends have told him that that will help with his blood pressure control. On the initial laboratory and physicals, he has a BMI of 29.5, so he's overweight. His blood pressure averages about 145/92, He has a serum creatinine of 125. And as I mentioned, we don't look at serum creatinine in isolation. He has an estimated GFR of 58 mils per minute. A urine protein of 2 classes, urine albumin creatinine ratio of 45 milligrams per millimole, and that equates to 450 milligrams of albuminuria daily. Has an HbA1c of 5.6% and LDL cholesterol of 4 millimoles per liter. So at this point, we'll be asking ourselves, what are our initial concerns? And I'm sure we all agree that the blood pressure is poorly controlled because he has a BP above 140/90. He has kidney dysfunction because his GFR is less than 58. There's severely increased albuminuria, and that is the A3 category because the albuminuria rates are more than 300 milligrams in 24 hours. Of course, the LDL cholesterol is elevated. And another cause of worry is the use of herbal medications. Most of these are nephrotoxic and can actually worsen kidney dysfunction. He's also overweight. So there are a lot of cardiovascular risk factors that this patient has. And as we mentioned, cardiovascular disease is a major risk factor for mortality or a major cause of mortality in a patient with CKD. So what should we consider next for this patient? Does this patient have CKD? Does this patient not have CKD? So I don't know, if we were in person, we would probably ask for a vote to know who thinks this patient has CKD or not. But per the discussion that was made earlier on, you need to have these abnormalities persisting for more than 3 months. Either your GFR less than 60 or urine albumin creatinine ratio less than more than 30. So in that case, you can call this a CKD if it's persisted for more than 30. So let's assume this patient has had previous records of these elevations in albuminuria, as well as decline in the GFR for more than 3 months. So we are certain that Mr. Lawson has CKD. What do we do next? It's always very important that we need to risk stratify this patient. For most of us, because we say GFR less than 60 is a cutoff for CKD, we'll think that, oh, 58 GFR is not so bad. But if you were to put that in the context of the heat map, alongside an albuminuria of 450 milligrams in 24 hours, you would realize that Mr. Lawson is actually at a very high risk of progression of the CKD, as well as cardiovascular disease, mortality, and morbidity. So it's very important that we always have a mind view of this heat map so that we can actually manage our patients with the urgency that is required. In general, the management of CKD involves a comprehensive treatment strategy involving a multidisciplinary approach, including family physicians who I think should be diagnosing early CKD, including dietitians, endocrinologists, cardiologists, nephrologists. So the management of CKD shouldn't necessarily be at the doorstep of the nephrologist. We would expect a multidisciplinary team. And the essence is to reduce the risk of progression of CKD, as well as associated complications, such as cardiovascular diseases. And this can be achieved beautifully by our family physicians who are, best at education concerning lifestyle modifications, exercise, and all that. Of course, the whole idea is that we need to protect this patient from developing advanced kidney disease. But as well as slow down the progression of kidney disease. Again, it's important to emphasize that, as I mentioned, beyond lifestyle medication, pharmacotherapy, it's actually the cornerstone of treating CKD and delaying or preventing its progression to end-stage kidney disease. In general, effective treatment of CKD would include both direct, I think the slide is not moving, yeah? Okay. Treatment of CKD includes both direct and indirect approaches. Indirect approaches would target the risk factors that would lead to the development of CKD. And this includes managing your high blood pressure, managing your dysglycemia, and other risk factors. Again, direct treatment would involve directly attacking the process of CKD development or progression, which will be the focus of some of the pharmacotherapeutic medications we'll be talking about as the presentation goes on. So there is definitely evidence to suggest that optimal blood pressure treatment improves patients' outcomes by reducing CKD progression and therefore reducing the risk of ESKD, reducing incidence of cardiovascular events, and reducing all-cause mortality. It is therefore important that for all our patients, we need to optimize blood pressure control. Of course, there are several guidelines that look at what is the optimal blood pressure for an individual. First of all, the blood pressure should be less than 140/90. For people who have more albuminuria, we would expect lower levels of blood pressure control. So you'd probably look at 130/80. Indeed, the SPRINT study, which was in patients over 50 years in non-diabetics, actually recommended systolic blood pressures of less than 120, and that reduced all-cause mortality. However, these were blood pressures measured in very strict conditions where the patient was unattended to, was alone in the office with the blood pressures measured, and that actually gave the optimal blood pressure. So in our normal clinic settings where there's so much activity going on and we clinicians are measuring the blood pressures, this may not be a safe target to look at in terms of blood pressure monitoring. It should be individualized, and so elderly people who are frail or who have frequent falls you would want to spare them of this very tight blood pressure control. There's also evidence to suggest that optimal blood glucose control would reduce the onset of CKD development or CKD progression or adverse events amongst diabetics. It is therefore very important that we optimally control patients' blood pressure, blood sugars. Generally, target HbA1c would be less than 7%. Again, that has to be individualized with less strict control in patients who are elderly or have more severe comorbidities or who have poor life expectancy. But it's important to realize that despite treatment or effective treatment of the blood pressures, blood sugars, as I've mentioned, patients with diabetes or hypertension still progressed. So it meant that we needed to do more. We needed other therapeutic approaches. And you can see from this diagram that even with the optimal treatment and a relative risk reduction of about 44% in terms of reducing end-stage kidney disease, there was still a significant residual risk and people still progressed to end-stage kidney disease. This actually led to the fact that we needed other more potent or additive pharmacotherapeutic agents to help reduce that residual risk of CKD progression or cardiovascular disease amongst our patients with CKD. And there's a lot of evidence to suggest the role of RAS blockers, SGLT2 inhibitors, the non-steroidal mineralocorticoid antagonists, as well as the GLP-1 receptor agonists in benefiting patients with CKD. To better understand the role of these agents, we need to understand briefly how CKD progresses. Centrally, you would have RAS activation and systemic hypertension being the key drivers of CKD progression. These act by increasing glomerular hypertension or causing glomerular hyperfiltration, or leading to inflammation or oxidative damage, including fibrosis. These eventually lead to proteinuria, glomerulosclerosis, or tubular interstitial fibrosis, and therefore leads to CKD progression. So once we understand this pathway, you would realize that these agents help to counteract these processes and therefore reduce the rate of progression of CKD. So from this previous slide, you realize that if you address the glomerular hypertension, which we said was also key to the progression of CKD, you may actually decrease intraglomerular pressures, reduce albuminuria, and cause less eGFR decline. And we all know the significant role ACE inhibitors or ARBs play in reducing glomerular hypertension, and that is how they actually lead to renal benefits. There's a lot of evidence to suggest the benefits of these medications. And indeed, This meta-analysis involving over 60,000 patients actually showed that using these agents reduce the risk of kidney failure and cardiovascular events amongst our patients with CKD. Because of the overwhelming benefits of RAS blockers, KDIGO actually recommends these agents for the treatment of CKD patients, particularly those with moderate to severe albuminuria. And indeed, it's also recommended for diabetic patients with albuminuria, even in the absence of hypertension. So just before I came to this presentation, we have a patient with CKD who has albuminuria, not hypertensive though. Lisinopril was prescribed for this patient because of the albuminuria. So she goes to the pharmacy. The first question the person is asked is, do you have hypertension? She says no. She's quite young though. And then the pharmacist says, no, you cannot be on this medication because you don't have hypertension. So this is one of the things we need to do in terms of educating our pharmacists and even educating our healthcare practitioners, such that some of these agents play other roles beyond just blood pressure control. It's also important to realize that in all these studies, they were beneficial in patients who had moderate to severe albuminuria. So you may not get the same benefits for people who have very minimal albuminuria. This is very important when we come to other newer agents that may be beneficial in our patients with CKD. It's also important to remember that in these studies that show the role of these agents, they actually use the agents at the maximally approved tolerated dose of these agents. So if you are giving someone lisinopril of 2.5 milligrams, you may not be getting the antiproteinuric effect as going higher and higher to a maximally tolerated dose. Again, even with the advent of RAS blockers and the fact that clinicians actually don't prescribe a lot of these agents when they should actually be, you still find out that there's still about a 40% residual risk of developing adverse kidney event. And these were demonstrated in the renal as well as the IDNT study. When a post hoc analysis was done, there was significant risk reduction of adverse cardiorenal event, but there were still people developing end-stage kidney disease, even though they were on these agents. This implied that we needed further agents. So the discovery of the SGLT2 inhibitors actually changed the game when it came to cardiorenal protection. In the initial cardiovascular outcome trials in patients with diabetes, there was a signal of the benefits of these agents in cardiorenal protection, I must say. Subsequently, the renal outcome trials, three of which are stated here in the Credence, DAPA-CKD, and EMPA-Kidney, actually showed that these SGLT2 inhibitors actually offered significant cardiorenal protection and reduced adverse outcomes in patients with CKD. Amongst them was the EMPA-CKD, and this actually enrolled a broad range of CKD population, including people with very minimal albuminuria, people with very low GFR as low as 20, and then people with higher GFRs as high as 60. So it actually included a lot of our patients, particularly people who are coming in early on, to see whether these agents will be beneficial in patients with early CKD as well as in late CKD, and to what level of GFR can we actually initiate these medications safely. So this study was stopped prematurely because of the overwhelming benefits of empagliflozin in the active arm. Indeed, in this study, empagliflozin resulted in a 28% risk reduction in adverse kidney outcomes, such as kidney disease progression, as well as reduction in cardiovascular disease. And this was quite immense. It's also important to remember that these beneficial results were independent of whether the patient was type 2 diabetic or not. It was independent of whether the person had a low GFR or high GFR. And it's also independent of the use of other baseline supportive therapies, such as RAS inhibitors. So this was a game changer when it came to kidney disease. And the point was that we could actually start these medications at a GFR as low as 20. Again, it also showed a 50% decline in the rate of progression of CKD. And this was actually very important news for our patients with CKD because there was now medications that can actually slow down the progression of CKD. Additionally, it actually reduced all-cause hospitalizations, and therefore patients coming with heart failure hospitalizations benefited from this as well. So this is actually a schema that looked at a typical patient who is on a RAS blocker alone. And typically the rate of decline of GFR would suggest that over a 10-year period, this patient will reach a GFR of 10 requiring kidney replacement therapy. The addition of an SGLT2 inhibitor to such a patient can actually afford this patient an additional 15 years from developing end-stage kidney disease. So the addition of an SGLT2 inhibitor to a RAS blocker can extend the person's duration to developing end-stage kidney disease. So based on all these studies, KDIGO again adopted SGLT2 inhibitors and guided that patients with type 2 diabetes and GFRs more than 20 mils per minute should actually benefit from these agents. And that's a class 1A recommendation, which is the highest level of recommendation. Additionally, any patient with CKD with a GFR above 20 and an albumin creatinine ratio over 200 would benefit from this. For a patient with heart failure, irrespective of the level of albuminuria, should also be prescribed an SGLT2 inhibitor. And more importantly, following the EMPA kidneys trial, adults with GFR as low as 20 to 45, even with very minimal albuminuria, should still benefit from these agents as well. And once initiated at a GFR of above 20, it is reasonable to continue these agents even until end-stage kidney disease, only stopping it once the patient initiates kidney replacement therapy. In addition to these agents, 2 other agents were proven in several studies to provide additional cardiovascular or cardiorenal benefits. In the Fidelio study involving the non-steroidal mineralocorticoid antagonist, finerenone, it actually showed that finerenone could offer additional cardiorenal protection amongst patients with type 2 diabetes who still had significant albuminuria despite the initial medications that we mentioned. Again, the GLP-1 receptor agonist also showed, particularly in the FLOW study involving semaglutide, that these agents can provide additional cardiorenal protection and may be used if an SGLT2 it's not tolerated, or if you cannot give SGLT2 for any indications. But again, you can add it onto an SGLT2 for additional benefits, including glycemic control. So the therapeutic overlap of these agents has been well demonstrated across the CRM spectrum, where you can use these medications across the spectrum of patients with cardiovascular disease, patients with kidney disease, and patients with metabolic diseases such as type 2 diabetes. And these agents exert both metabolic and cardiorenal benefits, including reducing cardiovascular death, reducing heart kidney outcomes such as development of kidney failure or worsening of eGFR. So back to Mr. Lawson. As we mentioned his profile, he had a BMI of 29.5. As we all know, we need an optimal BMI of less than 25. So again, our lifestyle, exercise, interventions may help with regards to that. Again, agents such as the SGLT2 inhibitors, and more particularly the GLP-1 receptor agonist in patients with type 2 diabetes may also offer additional weight loss. But again, our target is an optimal BMI of 25. What is our target BP? For this patient with A3 level albuminuria, we want a BP less than 130/80 or even lower if the patient can tolerate. And from this discussion, we are looking for additional antihypertensive agents to your amlodipine that provides other benefits beyond just BP control. And so the recommendation in this case may be a RAS blocker, such as telmisartan, lisinopril, or losartan. Our target UACR should be less than 3 milligrams per millimole. That is effectively less than 30 milligrams in 24 hours. And the agents that can do that would include RAS blockers as well as SGLT2 inhibitors. So these are definitely indicated in this patient as well. Then, of course, we need to reduce the cardiovascular risk in this patient, considering all the cardiovascular risk factors this patient has. One of it being the dyslipidemia, and moderate to high intensity statin would be used as well in terms of reducing this patient's cardiovascular risk. So I will conclude by saying that early CKD is usually asymptomatic. So if you don't look for it, you're not going to find it. How do you look for it? It's a combination of testing for albuminuria, using a urine ACR, as well as assessing or estimating the GFR from a serum creatinine or serum cystatin C if available. I'll mention that there are clear guidelines to support the management of CKD once diagnosed. KDIGO guidelines are available, and in recent times, there's an overlap between all the societies. When you go into the ADA guidelines, IDF, KDIGO, cardiovascular guidelines, they all lead to the same story that these agents provide optimal benefits for our patient. And I'll use this opportunity to say that we actually, as Ghana Kidney Association, have CKD protocols, which is available online. And so you can look at that, which it looks at how we would manage CKD in our part of the world. Finally, I would say that primary care plays a critical role in the fighting CKD. CKD is part of primary care, and would expect the family physicians to identify these patients early, institute these life-saving or organ-saving medications, and refer them appropriately to us. Primary care physicians should provide the foundations on which the nephrologist can provide further optimal care to our patients. So as a take-home, I would conclude by saying that in patients with evidence of kidney disease or at increased risk of developing kidney disease, such as people with diabetes, people with albuminuria, people with hypertension, the guidelines recommend use of renal protective and cardioprotective agents, such as RAS blockers, SGLT2 inhibitors, as well as the newer agents, MRAs and GLP-1 receptor agonists. So let's act now to slow down CKD progression. Thank you very much for your attention, and I'll be willing to take some questions.
Thank you very much, Dr. Inusa. The last statement is that let's act now to slow down CKD progression. It says that it's asymptomatic, and the earlier we diagnose and start guideline treatment, the better to be for our patients. It says that with our diagnosis, we are not only going to rely on our eGFR, but let's always look for albuminuria. That will guide what we do as well. And as primary care physicians, the challenge has been thrown. It means that if you're going to have a high number of CKD cases in the country, it means that we are the fundamental cause. So the challenge has been thrown, and we take the challenge. And I hope that with this information that have been provided by both Dr. Baba Damoah and Dr. Inusa, we are well equipped to make sure that the number of cases and the prevalence of CKD is going to go down. Thank you very much, Dr. Inusa. Please be putting your questions. I know there are a lot of questions that are coming in. Please be putting your questions in the Q&A section as we invite our partners to give us a presentation. So this presentation and CPD is supported by Boehringer Ingelheim. We've been with them for the past, I think, over 7 years, 8 years. They've been good partners. They've supported us, not only supporting us in this education, but I think that they've also supported the country in terms of good medication that they've brought into the system to support our management. So thank you so much. And thank you for partnering us in this section as well. So to give the presentation, we have Farm Prince Appiagyei, who is going to give a presentation to us on a topic. So Farm Prince, the floor is yours.
Hello. Hello. Is it better? Yeah. I want to start by asking a few questions. For those of us at home and then those of us here, how many of us would want to buy a car that has the airbag being disabled? I'm probably sure that none of us would want to do that. because no matter how careful we are, none of us plans for an accident, but we still want protection when it happens. And the truth is that after the accident, it is too late to install the airbag because you may have lost someone that you love, probably yourself. And so you'll not even be able to install the airbag now. Now, 3 years ago, a friend of mine called me around 9 p.m. when I was just about to sleep. And then he was crying. He was crying because his uncle had just been diagnosed of end-stage kidney disease with an eGFR of 8 ml per minute per 173 square meters. I remember this because of the time and because of the fact that he was crying. I know this uncle very well, and he had been diagnosed of diabetes for almost 15 years. And so it may have been other things that got him to the end stage, but I'm pretty sure it was the diabetes. He was very well managed anyway, but he was mostly on just metformin. 8 months later, on dialysis, which they could afford 3 times a week, the whole month, 8 months later, he died. And to this day, I still believe that experience may have been preventable. Because today we've heard Dr. Inusa talking about SGLT2 inhibitors and how they protect the kidneys. Not just that, they also manage the diabetes. And, you know, in this patient, you could have used 1 stone to kill 2 birds. Boehringer Ingelheim with us help us manage diabetes, our heart failures, and then also protect our kidneys. My name is Prince Alex Apiejiose from D, and I'm here with my boss, the country manager of Boehringer Ingelheim, Mr. Jonas Mati. In the next 10 minutes, I'll crave your indulgence as we discuss the super protection that Jardiance brings to us. As Inusa mentioned that from the EMPA kidney trials, the research shows Jardiance is able to give you about 15 more years before dialysis. If you can see my screen, there has been projection into this using the data from the EMPA kidney trials. And you can see that if a patient has eGFR of 85, without Jardiance, you are giving them 17 years before dialysis. And so if the patient is 40 today, it means that by the time they are 57, 3 years before they get to pension in Ghana, they would be on dialysis and they will be spending about 5,000 cedis monthly for dialysis. But if you give them Jardiance 10 milligram, whether just for diabetes or without diabetes, you are giving them 44 more years before dialysis. And so again, the same 40-year-old will turn 87 before they get to dialysis. And so you can imagine how much favor you'll be doing a patient who has diabetes alone, or even doesn't have diabetes, but with an eGFR of 85 today. Sometimes patients will come back to us happy because we help them get better. Other times we may never see those patients again because the medicines we gave them didn't make them better. And so they rushed or ran away to other prescribers who didn't do anything different, but added the drug you didn't give them. And because of that, they got better. They will sit somewhere and say, oh, Dr. Wade Onyade, this doctor doesn't really do well. But you did the diagnosis right. It is the medicines that probably you didn't choose carefully or you thought the patient couldn't afford. Research is showing that patients with CKD are 3 times more likely to have a cardiovascular event. So today we're not just talking about even the CKD, which 1 in 3 patients in diabetes will have. But again, we are protecting the hearts, we are protecting the kidneys, and then we are managing the diabetes. Before a patient comes to you, for you to even diagnose them of type 2 diabetes, as frontliners, as family medicine physicians, we are the frontliners. And so it's very important to know that 5 years before they saw you and you diagnosed, the development of microvascular complications may have already started. 10 years before, the atherosclerotic development had already started. And then 15 years before, the risk factors for cardiovascular disease had started. And so when you are seeing them, it's not a time when you want to go slow. You want to start slowly, but then you want to hit them where they are by giving them some of these medicines that would save their lives. Jardiance helps protect a broad range of patients with heart failure, CKD, and type 2 diabetes by reducing by all the percentages that we see. I do not want to bore you with the percentages, but this is to tell you that there's been clinically significant evidence to prove that Jardiance protects the kidneys, manages the diabetes very well, prevents them from getting to cardiovascular disease, and prevents them from hospitalization due to heart failure, especially reducing ejection fraction and preserved ejection fraction heart failures. Dr. Inusa mentioned about the progression to kidney disease, and Jardiance has been found to reduce the relative risk reduction by 39%. Jardiance comes as 10 milligram and 25 milligram. For patients who we are just treating for CKD, we want to do 10 milligram. If the patient has diabetes and the eGFR is more than 50, you want to start with Jardiance 25 milligram, because that will give you a tight glucose control, so that as you are protecting the kidneys, you're also managing the diabetes very well. You may not necessarily need an additional drug if you are doing Jardiance 25 milligram. Jardiance is easy to use. As Dr. Inusa mentioned, it can be initiated down to an eGFR of 20 ml per minute per 1.73 square meters. And it's been proven to be safe and tolerable. Now, for patients who have an HbA1c more than 9.5%, you want to do Jardiance and metformin in a combination we call Synjardy. Synjardy is able to do an HbA1c reduction of up to 4.6%. And just yesterday, I got a call from a physician in Takoradi who was so happy because he had a patient whose HbA1c was around 14.7, even on insulin. And just a month after he put him on Synjardy 12,500, the patient is coming back yesterday with an HbA1 reduction of 8.2. Well, the research is saying in 3 months, you should get 4.6% reduction. But I would say that in this patient, we've had more than 6% reduction, and it's very phenomenal. I believe that if we are putting our patients who need metformin and Jardiance on Synjardy, we'll be doing them good. Some prescribers would say that with the numbers that we are sharing, it may have been because of the conventional risk factor changes like diet and exercise. But then the research has also proven that, for instance, when it comes to all-cause mortality, the research data shows 32% relative risk reduction, and only 12% of that is as a result of their diet and then their exercise modification. When it comes to the cardiovascular death, which is 38% relative risk reduction, only 6% of that is as a result of diet and exercise. And for heart failure, which is 35%, only 11% of that is attributed to the diet and exercise. When it comes to relative risk reduction in the incidence of worsening nephropathy, which is 39%, the data shows that none of it is attributed to European Association for the Study of Diabetes. The recommendation, give me a second. Network is going up. Yeah. Okay, I think it's back. Okay, sorry for the technological lapse. The recommendation from the American Diabetic Association and the European Association for the Study of Diabetes is that for our patients who are 1.5% above their goal, their HbA1c goal, we would want to give them dual combination therapy. So something like Jardiance with metformin in a combination Synjardy. Now, as much as possible, you don't want to burden your patients with too many medicines. And so you want to give them one medicine that can kill 3 birds like Jardiance. But in this case, because you still want to add metformin because the HbA1c is more than 1.5% above the goal, you want to do Synjardy, which comes as either 5/1000, which is 5 milligram Jardiance, and then 1000 milligram metformin. You give us BD. So at the end of the day, you have your 10 milligram of Jardiance and 2 gram of metformin. Or you can do 12.5/1000, which is in effect 25 milligram of Jardiance daily and then 2 grams of metformin daily. So this is how the Synjardy looks like. And the Jardiance are the right, on the left. So if you do the Jardiance with the metformin, then you are getting Synjardy, which is a single pill. So there's ease of taking the medicine, and then there's also adherence. Now, in summary, we want to remind you that as frontline physicians, Jardiance is also a first-line choice when treating CKD, when treating type 2 diabetes, when treating heart failure, and has been proven to be safe and tolerable across multiple trials. And it's also an easy choice to protect your patients, especially because we don't want them to get to dialysis or need kidney replacement therapy, which is very expensive. And then if you ever want to combine the benefits of empagliflozin with metformin in one convenience pill, then you want to choose Synjardy because it significantly reduces HbA1c. There are different dosing options to individualize your patient treatment, and that's also proven safe. It was proven to be safe. And then also there's 38% relative risk reduction in cardiovascular death, as well as 39% relative risk reduction in CKD. Thank you very much. Questions are welcome.
Thank you very much, Prince, for this presentation. Indeed, I mean, I think these medications are in to support and to help us. And I hope our primary physicians will get to understand it more and use it. But there are questions that are coming through. So my panel members, get ready for all this. The first one is going to Prince.
Hey.
You know, whenever you talk about medication, it's talking about price. And somebody is asking, wow. I mean, there's a statement that Jardiance and these medications, they do all. But they do all with L'Argent. So how much is it?
Okay,
in terms of the various...
So Jardiance is selling at the retail level at places like NS Chemist Top Up for 900 cedis. And Synjardy is also selling at the same price. So if you have a patient who needs metformin, you don't necessarily have to worry about the price of metformin. In fact, for all the ranges of Jardiance, whether it's 10 milligram or 25 milligram, and then for Synjardy, whether it is 5/1000 or 12.5/1000, they are all the same price.
Okay, so it's going for 900 cedis at retail. So get to know so that you can prescribe to your clients. Baba Damwa, doctor, able president. So one of your residents is actually asking you that what will be the approach for early detection or slowing down CKD progression in the elderly, as they tend to have some reduced renal function due to their age.
Okay, so thank you very much for the question. You are right. As people age, like I said, it's a non-modifiable risk factor for getting CKD. Your eGFR usually will decline. What you first need to do is to be sure the patient has chronic kidney disease, and that means that you are measuring the eGFR, you are scanning also to look at the kidneys, and then these abnormalities will have to go on for 3 months to confirm that the patient actually has chronic kidney disease before then you think about how we are slowing down the progression. So after the diagnosis, you need to put the patient on the heat map KDIGO has developed. So if the patient is on yellow, green, or orange or red, then it will depend on that. It will let you know the number of times you need to review the patient, review the labs, repeat the medications for this particular patient that they have. So you would have put it in perspective. Aside this, you will have to look at lifestyle modification, diet modification, reducing other risk factors. Because the interesting thing is that people with risk factors for CKD have compounded problems. So the patient may be old, all right, but may also have hypertension, diabetes, obesity, or something else. So you need to screen all this and reduce that risk. Then you also need to reduce the other things that you can tell the patient, such as not abusing NSAIDs, some antibiotics, avoiding medication, some toxins, all the other risk factors we have learned about this afternoon. This will help to reduce the progression over the period. Thank you.
Thank you very much, Dr. Babadamo. Dr. Nisa, so the primary physicians are asking, I mean, they're talking about SGLT2. That time they are confused as to, I mean, you've talked about it. I mean, you mentioned some indications. Some of them are straightforward, some of them are confusing. And they are asking that, can you give the indication, the clear indication for the use of SGLT2 in primary care? Clear indications for the use of SGLT2 in primary care.
Yeah, thank you very much for that question. So basically, from all the studies that have been conducted, SGLT2 span a whole lot of indications. Initially, they were developed as diabetic medications, and the studies showed they had extra benefits beyond just glycemic control. And those benefits included renal protection as well as cardiovascular protection. So from the KDIGO point of view, for any diabetic, as long as the GFR is above 20, SGLT2 should really be your first line, probably in addition to metformin for glycemic control. Then you can add on other agents for additional glycemic control. For patients with CKD, as long as the GFR is above 20, as I mentioned earlier on, there's a class 1 indication for those who have albuminuria more than 200 milligrams in a day. So if you have a patient with CKD with a GFR above 20 who have albuminuria more than 200 milligrams per day, then you actually have a role, a place for SGLT2 for both renal protection and cardiovascular protection. Again, even amongst those with CKD who have quite low GFRs, in the absence of albuminuria, you would have SGLT2s playing a key role and in protecting the kidneys and the heart. Another key indication for SGLT2 inhibitors, it's its role in patients with heart failure, be it heart failure at reduced ejection fraction or heart failure with preserved ejection fraction, which had eluded us for so long because there was no evidence-based medication per se in those patients. So SGLT2s play a critical role in patients with heart failure with reduced ejection fraction, as well as those with preserved ejection fraction. So those are the key indications when it comes to KDIGO. And the same applies across most of these other guidelines, including the ADA and then EASD guidelines and cardiovascular guidelines. Thank you.
Thank you very much. Indeed, that's why they call it the magic drug. But as they call it the magic drug, I have a question that is talking about side effects. One of our people is actually asking that they have clients who are known to have diabetes without any other complication that they've put on this medication, and the client comes back and want to stop the medication because of side effects. Can you tell us some of the side effects and what they should do to convince this client? Because they know that it's indicated, it's good for them, but the client says that because of these side effects, I'm not going to go on this medication. In fact, I've had 2 of such clients, but what should we do? What are the major side effects and what should the primary care physician do in this case?
Okay, thank you very much, Doc, for the question. I'm trying to show this on the screen so that we can compare the side effects profile of Jardiance against placebo during the research. The truth is, the ones we see on the ground may not necessarily be what the research showed. But again, practically, I've only had 2 patients since I started working with BI who have got the feedback that they had candidiasis. And you can see from here that genital infections in Jardiance, there was a 4%, but in placebo was 1%. Even in those patients, when the physician told them to wipe properly, they never came back with a side effect. And they've been on the drug since December 2024. In fact, for the urinary tract infection, which we may think that because of its mechanism of action, more patients will even come with that. You can see that placebo has 7.2% and then Jardiance has 8.8%. The side effects, if you are looking at Jardiance, it's not really something that is bothersome because hypoglycemia is not a side effect, which is a side effect of most of the anti-glycemic agents. But for the urinary tract infection and the genital infections, you can see also that the rate at which patients will come with that is not so much. So for the UTI, you tell them to drink more water because of its mechanism of action, and you reduce that drastically. For the candidiasis, if you tell them to wipe properly, and they do, most times it resolves it and it never comes back again.
What about the increased frequency in nocturia? It's been one of the
side effects,
complaint of clients.
Yes, so not necessarily the nocturia, but again, the mechanism of action is such that it's taking away the excess blood sugar, which is not being used properly in the blood. And so by that mechanism, it will come with water. But again, if you are telling them, especially if they are taking Jardiance and you are telling them to take it in the morning, then they don't have to be disturbed by the frequent urination at night. But that also is not something that we found in most patients. And so as much as possible, we tell them to take the medicine in the morning. And then also, if they start having that effect, we tell them the time to take it so that they don't have so much of that. And also not drinking too much water just before they sleep.
Thank you very much, Prince, for these tidbits. I hope we got it so that we can advise our clients when they are taking it. Dr. Baba Damoa says that if a hypertensive patient with serum urea and serum creatinine above 3 times upper limit, understand CKD diagnosis should not be a single snapshot, but over a period of 3 months. In this case, will my working diagnosis be query CKD or AKI? A repeat test is done until a repeat test is done. Can you help us with this?
All right, thank you very much for the question. So your creatinine levels are high. I want to assume you mean your EGFR will also be low to commiserate at the level of CKD diagnosis, so 60 and below. So because it can also be an acute kidney injury, yes, you need to verify and be sure it's CKD before you can label that diagnosis per KDIGO guidelines and what I described. But the brilliant side of it is, even if it's AKI or CKD, the management for acute management is the same. So if you think the patient is AKI and has all the emergency things that will need the patient to have, let's say, dialysis. The patient has pulmonary edema, hyperuricemia, or whatsoever. The patient can receive whatever care that is urgently needed for the patient. You don't need to label the patient as a CKD or AKI to be able to receive that care. So you go on to manage the patient and you follow the patient up clearly. And like I said, some of the things are gaps, mixed gaps. So go back to the patient charts. For all you know, there had been a documentation of these high values somewhere in the charts that you have missed. That's why you are in the diagnostic dilemma. So when you go and check all these things, it will be able to help you make the right diagnosis. I don't know if Dr. Enusa has anything to add to that. Thank you.
Yeah, brilliantly said. So you said that we do get lots of referrals with a one-time creatinine elevation, and the diagnosis is CKD or end-stage kidney disease. So per the definition, as you mentioned, has to persist for more than 3 months. But you may have other proxies, right? So as we mentioned earlier, it may have been documented somewhere that the person had that creatinine elevation for so long and probably never detected, or nobody ever mentioned it. But the other things you can look at, there was a picture of a beautiful kidney that was put up in there. So sometimes just a look at the kidney ultrasound may give you an indication that this is probably something that has been going on, because the kidneys are small and shrunken or echogenic with lots of CMD. So with that in the presence of an elevated creatinine, you may assume that this is CKD. But mind you could always get an acute injury on a CKD. And that's why as clinicians, anytime you're seeing a patient for the first time with an elevated creatinine, I always say that even if there's CKD, assume that there's an AKI. AKI is reversible and manageable. So sometimes it's something as simple as an obstruction or some herbal medication the patient took or some infection. And usually if you're able to identify that and treat, there may be some recovery of the kidney function to his prior or his or her prior baseline. So let's always look out for any possible acute precipitants for anybody who comes with an elevated creatinine, rather than always jumping to CKD. Thank you.
Thank you very much, Dr. Enusa. This comes to you. My people are saying that they get a lot of problem from the radiologist, and when they are doing CT scans and with contrast, they are asked to do biocreatine, and when the kidney function, the EGFR is low, the patient is sent back. What should they do in this case? Should they go ahead with it and after that dialyze, or have some form of treatment before that is done? Because a lot of times they don't have any other option than to do a CT scan to help the diagnosis. So in such scenarios, what are your opinions and comments about it?
Okay, thank you very much. That's an interesting one, because I'm actually carrying out a study in predictors and then risk factors and prevalence of contrast-associated nephropathy, as it's called, the contrast-associated AKI, as it's called these days. Preliminary results actually shows very low prevalence actually, or very, very low incidence. And I think because you are taking the precautions. So I do understand the dilemma. There's a risk of developing an AKI if you give iodinated contrast to someone who has renal impairment, okay? Most often than not, if you really have to do it, the questions are, is there an alternate, safer imaging that you can do for this patient? If you can get whatever diagnosis you are looking for without doing a contrast, fine. Otherwise, there are preventive measures. You can actually prehydrate, and indeed, in all the studies, that's what has been shown to prevent or reduce the risk, okay? If you hydrate this patient before and after, you may actually reduce the prevalent or the incidence of contrast-induced AKI. But with those with very advanced kidney dysfunction, maybe GFR in the 10s, 12, 15, you want to do a contrast study. Of course, you would say that person already has kidney failure, so you can give the contrast, but that's a wrong thinking, because even in the presence of kidney failure, the person still has a residual kidney function that you want to preserve. So you don't want to destroy the remaining kidney function. People would say, do the contrast and dialyze. Doing the contrast and dialyze doesn't protect the kidneys, because by the time you finish your contrast and go in to do your dialysis, whatever mechanisms of kidney injury would have taken place already. So the only benefit of doing the contrast and dialyzing, particularly with those with advanced kidney disease, is because you don't want contrast buildup and other effects or side effects of a contrast, not necessarily because of a kidney. Whatever the contrast does to the kidney is almost immediate vasoconstriction, immediate free radical formation. So you cannot do it and go and do it. So prevention is always better than cure. If there's an alternative imaging that you can use that. If you need to do it, you need to identify the risk. People are elderly, diabetic, severely impaired kidney function, people are hypertensive, dehydrated. The most important thing is prehydration before the procedure and hydration after the procedure, and then monitoring the kidney function going forward. Thank you.
Thank you very much, Dr. Inusa. I think that we have some direction here, but there are times that you can't do anything, especially if you think that there are other alternatives. Please use those alternatives rather than using contrast on this client. Prince. So they are asking a very important question here. Now, when it comes to weight loss, I mean, a lot of people want to reduce weight, but they don't want to exercise. I mean, I don't know why people want to go that way, and they don't want to diet. But they're asking, your magic drug, can it help with that in terms of supporting weight loss in our clients?
Yes, Doc. Jardiance has been found to reduce weight by up to 5 kilograms. I'm trying to find the reference for you, but there is evidence in the EMPA-REG outcome trial that shows that Jardiance reduced weight just about 5 kilograms. Even BP reduced both systolic and diastolic blood pressure by about, I think, diastolic by about 4 millimeter mercury and systolic by about 7. And so, yes, though it is not indicated for reducing weight, as some medicines have been, it has a little bit effect on reducing the weight of the patient.
Wow, that's quite interesting. I'm sure people may be rushing to the pharmacy for this medication.
Not that way.
Dr. Inusa, so this question comes, I heard you like a lot of research, and they are asking that, what will you say are some urgent research areas at the molecular level that will further enhance kidney disease prevention and treatment?
A very, very interesting question. So basically, there's a lot of studies going on in kidney disease. And as you rightly said, most of these manifestations of diseases you are seeing, they've actually traced it back to the genomic level or even a molecular level. A case in point is the ApoL1. I'm sure the questioner may have seen that it's been shown that some risk or high risk variants of the apolipoprotein L1 actually increases our risk of developing kidney disease and increasing the risk of CKD progression. particularly non-diabetic kidney disease, people with HIV, people with FSGS, and that is predominant in people of African origin. And we are doing certain studies on that here in Korle Bu, where they are using certain molecules to prevent or reduce the adverse effects of these increased race variants. And there are promising results from that in terms of reducing proteinuria and even slowing down the progression. So that's a clinical trial that we're doing currently. But beyond that, there's a genetic basis for majority or molecular basis for majority of our kidney diseases. There's a whole lot of research in IgA nephropathy. It's not made so much noise in our part of the world because we don't tend to have a lot of IgA nephropathy. But then again, if you look at it, if you look at things like ADPKD or polycystic kidney disease, the genetic bases are in there and people are actually looking at certain molecules that may reduce that. So there's definitely a lot going on. And of course, we should be available to do the research. And when we get collaborations from external collaborators, we should be willing to partake. We've had a lot of troubles recruiting people for this clinical trial involving the APOL1 high-risk variant because we've struggled to get physicians referring cases to us. So we should all take part in these things when we get the opportunity to do that. Thank you.
Thank you very much, Dr. Inusa. Please, let's try as much as possible to talk to our clients as well. All this research that are ongoing is supposed to help with clinical care and improve the quality, and of course, give enough knowledge to help our clients. So let's be involved and let's, we are close to our clients. So when we talk to them, they listen. So kindly do us that favor. Dr. Barbadamu. So when we talk about herbal medication, it can be a whole 2-hour talk on TV where they are talking about all sorts of things. Can cure everything by medication. I think it's only Jardian that is getting close to herbal medication, where it can do the magic and work on a lot of things. But they are saying that, what's your take in patients taking herbal medications in relation to CKD? Because we talk about it a lot. Meanwhile, it's been promoted on every radio station, every TV station. And how can this chain be reduced? Because it's a major cause of kidney disease, chronic kidney disease, then there should be something.
All right, so thank you very much. I always say, writing your own canna. So as you see patients, your day-to-day activity, your advocacy is what the patient will take to their home, to their immediate family, who will now carry on to the community where they live, and then it will go on. As family physicians, we advocate for, there's a room for complementary alternative care in whatever condition that you have. But this herbal medication must be something that has been studied, approved, and screened to be safe to be consumed before you use it for whatever medical treatment you are looking out for. So when I sit with my patient and I ask for my drug history and they tell me they're on herbal medication, I go ahead to find out what exactly they are on, whether it is approved and is for what purpose. And sometimes just drawing their attention to it makes them realize the need for not to take those medication. And especially when it's something they have done by themselves, boiled it, cooked it, or somebody have told them or something. Because sometimes it can be heartbreaking when you have end-stage kidney disease, you have to be on dialysis, you don't have money to do it. Anything anybody tells you that it will cure your kidney problems, you run at it. So it is dialogue and you speaking to these people for them to actually understand how harmful these herbal medications are causing them. And they will in turn carry the information to their families. Their families will in turn carry the information to the communities on that level. But having said that, there should be policies and other things that drives how, like you said, advertisements of these medications and herbal things are done on the internet. Sometimes they will tell you that it's when you actually pick the medication, it's written for general well-being. But when they are talking about the medication, oh my God, it can heal everything from your head to the sole of your feet. you know. So it's awareness, 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 and advocacy. So that's what I would say that we can give for our patients. Thank you.
Thank you very much, Dr. Baba Damon. Dr. Anusa, looks like people want to use SGL2 by all means. So they're asking, you said EGFR more than 20, stating EGFR more than 20. So there are two questions that are in. So it says that what if it's about 15? Another one is saying, I mean, just below 20, 19, has all the medications. Should we still use it? And a follow up to that one, somebody, I mean, when they talked about 900, I actually heard from the PCA, 900. So they're asking, the Ghana Medical Trust Fund, does it support CKD management so that they can get some of these magic drugs in their management? If we can take these two questions for us.
Yes. Okay, thanks for the question. So, you know, as clinicians, we are guided by clinical trials. So per the clinical trials, you realize for people who have advanced kidney disease, in most clinical trials, people with GFR less than 30 are not even included. So we don't even know the safety of most of these medications with GFRs less than 30. So when EMPA kidney came, they actually went below to as low as 20. Okay, so from that, the guidelines actually said you can go as low as 20. So that's what the guideline says. And so that's what they have been licensed to sell or to tell us, right? But of course, if you start at a GFR above 20, you can continue all the way till the person is starting kidney replacement therapy. And indeed, there are smaller studies or studies ongoing to even look at the safety of these medications in patients who are on dialysis, particularly people on peritoneal dialysis. One thing I would say is that in the initial stages of these studies, when they recruited patients, they had a run-in period where they made sure that they were already on standard of care, made sure that people were on RAS blockers and all that. And by the time they actually started the study itself with either giving placebo or the active agent, quite a number of people had GFRs less than 20 anyway. So they were started either ways, whether GFR was less than 20. But per the indications as it stands now, it's a GFR above 20, but you can continue it all the way to the person starting kidney replacement therapy. The challenge here is that in a lot of cases, when you do start these medications, per their mechanism of action, there's an initial dip in the GFR. That leads to a lot of anxiety. Assuming somebody has a GFR of 18, and then you start an SGLT2 inhibitor, and within a month to two, the GFR drops by about 3, which is usually the allowable limit, goes to 15. The person is definitely going to be very anxious of this drop. A lot of people do understand that these drops are just hemodynamic, and I've proven it to my patients a couple of times. Oh, that drop is, when they get so anxious, like you stop their medications and see, you realize the kidney function comes back to its level prior to the starting. And that convinces them that, oh, it hasn't destroyed the kidney. It's just the way it works. So imagine starting somewhere at the GFR of 15, and then it drops to 12 or 11. There's a lot of anxiety provoking. So I tend to stick to the 20s. Nothing at all, 19. But for now, the licensing or indication is 20, and then you can go as low as that. With regards to the essential medicines list and all that, as far as I'm concerned, these medications are not yet on our essential medicines list. So we've made some advocacy, one of it being the release of the protocols and all that. And GK, Ghana Kidney Association, has been a driver or a key stakeholder when it comes to negotiations like this. So hopefully in the near future, we can get these medications on board our essential medicines list, and therefore we can provide these patients at lower cost or even free to our patients, bearing in mind that prevention is always better than cure. And in more advanced countries where they realize the benefit of these medications, they make sure that all their patients get it, because it's cheaper to put these patients on an SGLT2 inhibitor than to put somebody on dialysis, which the state is actually taking care of. Thank you.
Thank you very much, Dr. Inusa. It says that it's cheaper to put them on SGL2 than to put them on dialysis. So if they needed to provide for them, of course, not to go and steal to buy, but so that those who can afford can. Prince, so this comes to you. Sir, please, can you please throw some light on SGL2 inhibitors induce euglycemic ketoacidosis? How do we approach it if any of our patients experience such side effects of this very much important drug, this magic drug?
Okay, thank you very much for the question. I think I showed the side effects of Jardiance as much as possible because of its mechanism of action. Maybe let me reiterate it. Because you and I probably do not have diabetes, our kidney threshold for reabsorption of blood sugar is 180 grams daily. So as for those who have diabetes, because they do, their kidney threshold is moved to between 260 and 320. Now what Jardiance is going to do is to push that back to 180. And that is how come they will record even as low as 3.5 FPS. Now, because of this, the body tends to use the other pathways, the other gluconeogenetic pathways to produce the energy that is needed by the body. And so, yes, there will be instances where you have ketones in the urine, but then the rate at which patients will come with DKA is less. However, as a company, our stance is that if you have a patient who comes with DKA, you withhold the drug, you control the patient, then depending on the other factors, if the patient is undergoing surgery, you cannot put them on that because again, they may be at higher risk. If the patient is dehydrated, the patient can get DKA. So then when you are telling them to go back on the medicine, you make sure there's no infection, and then you make sure the patient is taking enough water. Most often than not, the issues with the ketones are resolved. And so, yes, as I mentioned, the clinical trial has shown it, and in everyday practice, patients are not so much coming with the DKA. And so that's one of the qualities that Jardiance has. And that's why probably the price would be around 900, but not so much because Dr. Inusa just mentioned there's still, I think 1/5 the cost of dialysis for just a month.
Okay, thank you very much, Prince. So our last question, I think we are almost for our last question to Dr. Inusa. So this is from a palliative care physician. And whenever they're talking about kidney disease and they don't talk about palliative, then it's not finished. So we are ending with palliative care. So it says that current guidelines, conservative care for end-stage kidney disease, the important markers to keep note of, and the role and timing of palliative or supportive care in kidney care. Then the second one is that what are your thoughts about advanced care planning for our patient with CKD? Who should initiate the discussion, and how can we collectively, that the primary care physician, the nephrologist, the palliative care physician, ensure the patient is adequately educated to make informed choices? Dr. Inusa, for you.
Okay, so I'll start with the advanced care planning. I must say that in terms of the clinicians' approach, I would say our family physicians do much better with patient counseling and all this advanced care planning. I'm saying this because I spoke with one of the consultants in your unit just 2 or 3 days ago for somebody who had quite an advanced kidney disease, and there was really no plan as to what to do for this patient. Now comes in unconscious, needs blood, family says no blood, and we don't know what to do with regards to that. So we're like, if we had to discuss these things. So I would say that the management of kidney disease is multidisciplinary, I would say again, and family physicians, nephrologists, cardiologists, endocrinologists should come together. And indeed, there's actually a push these days for forming CKM clinics, where you have the person is coming as a one-stop shop. There's a cardiologist there, a family physician, nephrologist, endocrine, and you can have all these things being discussed. There's definitely a room for conservative management of kidney disease. In our part of the world, we tend to use it a lot because people don't have money to even start kidney replacement therapy. So people involuntarily choose conservative management. But there are definitely patients, particularly the very elderly patients. I've had quite a number of patients, and a lot of them are hovering at end stage. It's a discussion that you would have in that, what are your wishes for this patient? Are you going to do a kidney replacement therapy, what are the pros and cons? At the end of the day, it's the clinician's duty to tell the family what the pros and cons are in terms of how you'd manage. There are people who would say, look, no matter what, we need to dialyze this patient even if it's 90. That's our wishes. But you need to let them know how frail is the patient, what's the life expectancy. The process of dialysis, hemodialysis in particular, is not a very easy process. In places where they have peritoneal dialysis, which is gentler, very elderly, frail people may do it. But of course, there's also palliative dialysis, where you may not do a full-blown 3 times a week for the patient. It could just be once a week, just to manage the uremic symptoms, whilst you also manage some of these other complications. So again, I would say that now that there's a very big or well-established palliative care unit, that was one of the discussions we had. We would definitely have to involve palliative care in these kind of patients, people with very bad comorbidities, advanced ages, frail, malignancies that, have poor life expectancies, so that we can have all these things put in place before they actually get there and we don't know what to do. Thank you.
Thank you very much, Dr. Inusa. On the note that the management of CKD is multidisciplinary. You can't do it alone. You cannot be at your corner trying to do everything on your own. On this note, I want to thank our panelists. Prince, thank you so much for Bowinga. And we know that next time when we call on you, you'll come again. In fact, your boss has actually promised that we're going to have multiple of these. So thank you so much, Bowinga, for your support. President, Dr. Baba Damwa, thank you so much. So eloquent, so informative your presentation. And my very good friend, Dr. Inusa, thank you so much. One of your students is actually saying that, yes, you're a very good presenter and a very good lecturer. So he's saying thank you for your presentation. Suffolk members, from the 21st to the 24th of May, we are driving and we are flying and we are swimming to Takoradi in the Western region, Western Premier. We've been working hard. We need to get there, relax, get information, and chill. All roads get to Takoradi. We are inviting everybody. When I say that, I scare my president, but we are inviting everybody to join us at Takoradi. Even if you are not a fan physician and want to be part of us, I've had a number of people who say that they want to be part of us. You are invited to come through to the place. There's going to be a lot of things that we're going to do, a lot of discussions. Let's come together and push primary care in Ghana. On this note, I say thank you very much for joining us. We have over 900 people joining us. We are very grateful for always joining us. We hope that these CPDs have been very instructive and helpful as we promote primary care in Ghana. So until we meet again at Takoradi, God bless you all. Stay blessed.